Welcome to La Vida Las Vegas podcast. We're two physical therapists living the life in Las Vegas. I'm Dr. Erica.
And I'm Dr. Joe. We created this podcast for two reasons. First, to connect the healthcare, wellness, and fitness communities in Las Vegas. And second, to highlight all the amazing people we've met along the way.
Thank you for listening, and remember to take care of yourself.
Today's guest is Dr. Tanita. He's an OBGYN from Las Vegas. He tells us about making the decision to go back to medical school, the different types of birth control available, and his love of educating patients about how their body functions. All right, welcome to La Vida Las Vegas podcast. Appreciate you coming on our show.
Thank you. It's good to be here.
Yeah, if you go ahead and introduce yourself and tell us what you do.
Yeah, my name is Dr. Douglas Tanita. I'm an OBGYN physician here in Henderson, Las Vegas area. And I have a solo practice in Henderson, Nevada, right off of Horizon Ridge and close to Eastern.
Very good. How long have you been doing that for?
Well, I've had the practice. It's a relatively new practice. I've been in Henderson since 2011. After residency, I came here. And I used to work for a bigger practice, bigger multi-specialty practice, but started this practice recently in this past October 2020. So I've been in town for a while and been delivering and seeing patients for a while, but the practice is relatively new.
Oh, congratulations. That's awesome. So what does an OBGYN do? Can you just, if someone doesn't know what that entails or
Yeah, I think 50% of men have no idea what an OBGYN is. OBGYN stands for Obstetrics and Gynecology. And basically it's a physician that focuses on females. So the obstetrics part is the having pregnancy related side of medicine. So delivery, prenatal care. And the gynecology part is female health in regards to, it can range anywhere from birth control to abnormal uterine bleeding, infections of the female genital tract, and menopause.
So what brought you to Vegas?
Yeah, so I'm originally from San Diego. I grew up in San Diego, beaches, surfing, all that good stuff. And my wife is from Granada Hills, so we're California people, as seems like most people in Vegas are there. You're either from California or back east. It seems like nobody's from Vegas, right? So I did my training, and I'd always wanted to go back to San Diego, and we kind of talked about where we wanted to kind of hunker down and settle down. And so California was kind of on our list, and specifically San Diego. So when I was done with residency and training and we were going to look for where to settle down, we looked at California, and like many people, we're like, hey, it's pretty expensive out here. And as far as San Diego is concerned, specifically, doctors are a dime a dozen out there. There's a lot of doctors, so there's not a lot of opportunity. Well, it didn't seem at the time back in 2011. So we thought, well, where else can we go? What would be close enough where we could see our family, drive out there? And then obviously there's a lot of taxes out in California. So we looked at, Arizona and Nevada. And so I think Phoenix and Las Vegas is close enough where you can make the drive. We have 3 kids. And so we weren't going to do a lot of flying. So we wanted someplace that's close that we could drive and see our family. So and there was opportunity here in Vegas. I applied. There was a couple of jobs. I applied, and that's how we made it here.
That's awesome. How did you get into becoming an OBGYN? Why was that particularly when you're studying medicine, that was your specialty that you wanted to go into?
Yeah. So my brother's a physician. He's actually an ER doctor. And well, let me give you a little story, step back really quickly. So my mom was born in Portugal and raised in Brazil. And she has an elementary school education. And so she was, education was going to be really important for us. So she used to tell us when we were growing up, Doug, I want you to do, when you get older, you should do what you love, but be a doctor. But you should do what you love, but be a doctor. so that got drilled in my head. And when you're younger, you're like, what do you like to do? It's like, well, I like to surf. I like to, eat tacos and sleep in and play video games, so when it was time for me to go to school, I was like, okay, I guess I'll be a biology major, so, and as it turns out, I really liked it. But anyways, so, when choosing my career, we can go a little bit more into that because actually medicine is my second career. When I went into medicine, when I thought about going into medicine, I had a family practice doctor that was my doctor, and I thought, wow, this guy's really cool. He's working with people, he's helping people, and I'd ask him questions. And I thought, yeah, that's something I think I want to do. And my brother ended up going into medicine and would pick his brain. And so initially when I went into medicine, I was thinking about family practice because, that's what I knew. I didn't know anything about surgery. I didn't have any physicians in my family, and my brother's my younger brother. So anyways, when I went through medical school and residency, or medical school, and you're looking at different, you rotate through like family practice, internal medicine, pediatrics, you have certain perceptions on what something is, and then you do the rotation. You're like, oh, it's not what I thought it would be. So when I did obstetrics and gynecology, which was really the last thing I thought I would go into, I mean, it was like, oh, that's for females, only girls go into that. I was working with actually a midwife who, there was someone who was laboring, and I was with her all day, and she actually let me help deliver the baby. And I was just blown away by, this delivering process. And I was like, wow, that was really, really cool. Everybody was healthy and happy. They were happy to be there. I just got done doing a rotation where, unfortunately, like, it was a medicine rotation, and there was a lot of people with cancer and they were dying. And it was kind of a sad situation. And gynecology and obstetrics was, people were happy to be there. You were able to build a relationship with the patient. And so as I looked into it, it was like, and I started doing more surgery too, participating in surgery, assisting. And so obstetrics and gynecology gives you the option of doing, medicine's kind of broken up into kind of two halves. You have like the surgical aspect of it, and then you have the medicine part. So the surgery would be like general surgery, orthopedic surgery, urology. The medicine's like cardiology, internal medicine, pediatrics. And so obstetrics and gynecology is actually kind of both, because you do hysterectomies, you do C-sections, you do procedures, but you also do the medicine side where you deal with endocrinology, you deal with women with hormonal therapy, menopause. And the one part I liked about medicine, like even with family practice, is, well, in general surgery, you may do an appendectomy and then the patient's gone and you never see the patient again. So, you're kind of like, you'll do a surgery and then they're done. There's really no long lasting relationship. But in gynecology, or in the obstetric realm as well, you can see a patient that comes in as a young teenager who's having bleeding issues or cramping issues, and you put them on some medication for that. Then they talk about birth control, and you can talk about starting them on birth control, then maybe they get married and then they have a baby, and you can see them for their pregnancy, 1, 2, 3 pregnancies, and then maybe they get a hysterectomy or tie their tubes, and then they go through menopause. And so you build this really lifelong relationship with your patients, and you can do the surgery and the medicine side. So all that combined, I mean, maybe that's a long version of, just, I saw that and I was really attracted to that and I really liked that. And so, yeah, there you go.
So what's it? I guess you probably have helped delivered hundreds, thousands of babies now these days. What is it like? What's that experience like for you going into that after multiple times going through?
Yeah, I mean, I guess if you've if you've been doing something hundreds, thousands of times, you get into what I guess I would say that initially when you do something for the first time, it just blows your mind. It sticks in your mind forever. and it's an amazing, it's as a student, you look at that. And when I delivered my first baby, it was just amazing. I mean, I was in awe. I couldn't, I was going, it was kind of scary and exciting all at the same time. But I wasn't the captain of the ship. I was kind of observing and participating a little bit. When you go through the training process and you're learning how to deliver a baby, what you're worried about, what your training is, safety first. And if something goes bad, what do I do? My job is to make sure that the baby is delivered and is safe, mom's safe, baby's safe. And so when you go through training, it's very technical and you're worrying about all kinds of things that can happen, and you're coming up with plans in the back of your mind on what can happen. So, I think it's, whereas, I guess it would be similar to flying an airplane. Like the pilot's looking at the weather and he's, looking at where they're navigating to. And in the meantime, everybody in the back's having a good old time watching videos and enjoying the flight. And so it's kind of like two different experiences. But, I would say that it is pretty awesome to be with the family, especially like first time moms. They don't know what's going on. They're kind of scared. You can explain to them, this is what you can anticipate, and hold their hand and show them, hey, this is what you can expect. And so that's really cool. But during the delivery part, I'm kind of keeping an eye on everything and making sure everything's safe. So I'm working.
Yeah. So
Yeah.
I asked you this too. You are a dad of 3. How was that experience as being the father in that situation? Not
Well, yeah.
not
So
circumstances.
I think I mentioned earlier. So medicine was my second career. I actually started medical school when I was 30. So when I started medical school, I was married. And then we went into residency, and my wife had our first son. And so actually our second son when I started residency. So a lot of medical students and residents are younger. Probably most of them are not married, and certainly most of them don't have children. And so I was kind of like the old guy. If you're married, you're old, right? And then if you have kids, you're really old. So I was kind of like, this older guy who's coming in. And so it was great. I mean, I actually really enjoyed medical school and residency, and I think it was one of the best times of my life. You wouldn't think that, you're working crazy hours, but it was great. And people actually would ask, how is it, being married in residency and you're working like 100 plus hours? And I was like, it's great. I come home, my wife's awesome. She's like cooks me meals and she does my laundry, and you poor suckers got to do that yourself. So I thought it was awesome. And then my kids were really young, so I was gone a lot. And so when they're really young, they're kind of like not really aware of that. But they would come visit me in the hospital, and they knew that there was this in the middle of the night I'd be on call, and there's this physician's lounge. So my wife would come visit me, bring my 2 kids, and there's this, you get free food in there, and there was like this ice cream area. So they knew where the ice cream was. They just beeline right to the ice cream, and they loved it. Actually, so I actually delivered my last my daughter, my last child. She's 10 years old, and it was my last year of residency, and my wife was like, "Hey, I want you to deliver," and I was like, "Okay, yeah." So I was like, "Oh, this is easy. This is your third baby, easy peasy," and it went great. And so yeah, so my daughter, she'll go around, she'll tell people, "Look, he delivered me. He delivered me." She gets a kick out of that.
So what was your first career if that was your second?
Yeah, so I went to school in Santa Barbara, UCSB, and like I said before, I was like, "Well, what's your major?" I'm like, "Well, biology," because my mom said I have to be a doctor. So I was like, "Okay, let's go biology. Let's go to medicine." My brother did the same thing. He went to school in San Diego, and so during that time, there was a big tech boom, and so everybody was getting into technology, and Santa Barbara was a big hub for that. And I had a lot of friends that were going into technology, doing programming and websites, and I was like, man, that's so cool. And I actually had a job working in the lab one of the computer labs, like a part-time job when I was going to school. And they were teaching me how to do Photoshop and do web design. And I was like, man, this is so cool. So actually I finished my biology degree, but I ended up doing web development. And then I thought, well, maybe I'll go this technical side, and either do something with computers. So I did that, and I got a job. Initially with it was a vitamin supplement company, and I did web development with them. And then I got another job, left them, and then got a job with the school district, and I did a little bit of tech support and networking. And then I started my own business, kind of a tech support consulting company, and would set up networks, small networks, some restaurants, back end stuff. And I did that. And then all of a sudden there was a big tech boom, and then everything went psh. And then I found myself struggling, going, oh gosh, I lived in Santa Barbara. I don't know if you know about Santa Barbara, but it's not for it's for the rich. There's a saying for what is it? The newlywed and nearly dead. So you got to have a lot of money or be poor. And so I was like, how am I going to afford a house? And, in this economy. And I actually had a conversation with my brother. It was over Christmas, and he was like, didn't you want to be a doctor? Like, hey, what happened with that? And I was like, yeah. It's like, yeah, I'm too old. I'm like almost 30, and you can't go into medical school. And he's like, yeah, you should try it out. And so I applied and got in. And I was like, yeah, I think I do want to go to medicine. So here you go.
Yeah, I did the same thing. I went back. This is, PT is like my third, fourth career probably. So I went back to school when I was 10 years old, and everyone else in my class too.
Yeah, you're an old guy too.
Yep, that's right.
Right.
That's right.
No old guys.
Yep, I was one of the old guys in the class.
Yeah,
that's all right though. Then people
wise guys.
Yeah. So when you're not working, what else do you do to spend your time in Vegas?
Oh, well, that's a good question. That's a big when I'm not working. When you're starting a practice, you're working a lot. But when I have free time, I love spending time with my family. So we just got back from Bryan Head. We did some skiing.
Nice.
My wife's learning to ski. She did a little bit of snowboarding. So I was like, hey, let's try you on skis. My kids love it. So they're just like, we went about a month ago. They loved it. And they're like, we got to go again. So we love doing any kind of traveling with the family. It's tough. There's 5 of us, so we don't do a lot of flying. So it's a lot of local stuff. Red Rock, hiking. We have 2 dogs, so we like to hike locally. So most of my free time is spent with my wife and kids, doing a little traveling, skiing. We also started getting into jujitsu. So like my brother, he's a jujitsu guy. He's got his blue belt. And he's like, yeah, you got to get into it. And I wrestled in high school, and so did he in college a little bit. And so my son and my daughter do jujitsu, and I've been doing it with them.
Oh, awesome.
Yeah, that's been rough. It's a lot of work.
Do you guys train with each other, like practice?
Yeah, my son, I do. Yeah.
Okay.
So he, we roll, and he's good. My daughter, she's amazing. She's 10 years old, and yeah, she's like wanting to do tournaments and all that. We just got started, so we're all white belts. Yeah.
Very cool. That's when you think of family activity, that's not always the one that you would think of, but that's good though. I like it.
Top on the list. Well, I may be seeing you guys for some physical therapy, man. I feel like I get beat up, man. These young bucks, man. I'm not a young buck anymore. Got these 20-year-olds throwing me around like I'm a wet noodle.
Right. So as far as for your career, like what are things that you would see that you see every day and it seems common to you, but maybe not so common to a regular person?
Oh, so something that's common to me that, well, I mean, I'm a gynecologist. There's a lot there. I would say that maybe, something that conversations I have all the time with women that I see some of the same questions over and over again, same issues, and we can talk maybe a little bit about that. Yeah. So for instance, we can start off with Pap smears or annual exams. So that's one that's a little confusing for a lot of people. So, women know about, hey, I got to go in and I get an annual exam, get my Pap smear every year. So there is a difference between, Pap smear and an annual exam. So typically an annual exam is just that. It's an exam every year. You come in, you talk about general wellness and health, talk about, menstrual cycles. It obviously depends on your age. Exercising, certain kind of screening you want to do. Pap smears included with that, mammograms. We talked about contraception, family planning, and that's an annual visit that women should come in, and we can talk a little bit about when women, at what age do you start doing that. In part of that is Pap smears. So before, women would get Pap smears every year with your annual exam, and that's changed. And so the confusion is, well, one, what is a Pap smear and why do I get a Pap smear? So a Pap smear is a test where you're grabbing cells from the cervix to screen for cervical cancer. And they would they used to do it every year, but because technology, we know more about cervical cancer, and we can do testing for the human papilloma virus, HPV virus, which is the cause of cervical cancer. The guidelines have changed. So now, so typically what happens is, in order for somebody to get cervical cancer, they'll be exposed to the human papilloma virus. And the human papilloma virus, most women who are exposed to the human papilloma virus, it'll go away on its own. But of the small percentage that it doesn't go away, it can cause the cells on the cervix to become abnormal. And if left unattended and it becomes abnormal over many years, could eventually become cervical cancer. So because most women, the HPV virus, it'll go away. And because it takes many years for it to develop into cervical cancer, we're able to, and because women have relatively good access to care, you don't see a lot of cervical cancer in the United States. Now, in the world, you do see it, but in the United States, it's not as much. And so what was happening in the past was women were getting these Pap smears. It would be slightly abnormal. And so doctors were treating these abnormal cells with procedures called LEEP procedures, where you cut part of the cervix out. And part of the problem with that is that can cause some issues with premature delivery on these younger women. And since a lot of women, and HPV is a sexual transmitted disease. So if you're getting HPV at a younger age, and most younger women, they haven't delivered or haven't gotten pregnant and delivered these babies, and since most women the HPV will go away, it makes sense to keep an eye on it, but to not do a lot of procedures on the cervix, especially when these women haven't delivered babies, and that can cause some problems in the future. And you'll need the HPV first then the cells become abnormal later. And because now we can test for the HPV virus, the guidelines have changed. So the guidelines are, you start doing Pap smears at 21 years of age. And when you do the Pap smear, if it's negative, you can do it every 3 years, because first you'll have to be exposed to the HPV, then it needs to cause the cells to be abnormal. And since most of the time the HPV will go away, you have some time there. At 30 is when you can start doing what we call co-testing, where you test for the HPV virus and looking at the cells. So if that's both negative, then you can do that every 5 years. Because again, first you need to be exposed to the HPV virus. Then if it doesn't go away, it can make the cells become abnormal. And then that takes time. And 5 years is enough time where you can keep a close eye on it. Because the last thing you want to do is do a lot of procedures on cervixes, doing these LEEP procedures on younger women, where most of them that it's going to go away and it'll clear on its own. And that could cause problems with pregnancy and preterm delivery. So that was kind of the thinking behind that. So the people go, well, am I supposed to have the annual every year, or is it every 5 years or every 3 years? What's the deal? And the deal is, you should have an annual exam every year, but the Pap smear part of it is every 3 years or every 5 years, depending on your age. So does that make sense? I mean, that's where, you can read online and it can be very confusing. So another issue is, when should women come in? Like if you have a daughter, it's like, hey, I have a teenage daughter. When should I bring her in? She's terrified of going to see an OBGYN. She's read some horror stories. She doesn't want to go anywhere near an OBGYN. So we recommend at a younger age, as their teenage years, especially if they're starting to menstruate. And the nice thing about coming in early is we don't usually do pelvic exams early on. So if a 12-year-old girl comes in with her mother, we can talk about, hey, how's it going with menstrual cycles? And it's just a conversation. And so the first couple of years, we're building rapport. We're talking about, what she can expect with menstrual cycles. Cramping is a big issue, what they can do for that. A lot of times we talk about birth control pills, and we'll often give birth control pills to help with cramping and bleeding, and not just for contraception. So a lot of them aren't sexually active, but we certainly talk about that as well. So it's a good idea to bring these younger girls in, especially if they're having menstrual cycles, and because there can be certainly problems with that. And then we can dispel a lot of rumors and issues, because you go online and, oh, my friend told me this and that, and it seems like 90% of it's not true. It's like, where'd you hear that? No, that's not true. So we can definitely clear the air with that.
That's really smart. That's something I didn't think about, as far as in the age of the internet here now, that, so many people are getting bad information. We have patients that come in all the time and the same thing. Like, they tell us something that they learned online. They're like, oh, I should be doing this one exercise, right? I'm like, I don't know. I've never heard of that exercise before. So
right.
I really couldn't tell you if you're supposed to be doing it every day. But that's good.
Yeah,
though.
it's a double-edged sword. I mean, the internet, it's great. There's a lot of information out there, but it's like drinking from a fire hose. How do you weed out the bad stuff? So, I mean, even educating patients, like, hey, look, there are credible sources that you should look at. The CDC, Acog stands for American Congress of Obstetricians and Gynecologists. So that's information where people can do their own research, but just look at credible sources. So I think that's super important.
Oh yeah, for sure. Context is everything nowadays.
Yeah.
Mm-hmm.
Yeah.
Is there anything else that you commonly see in common questions that you see?
Oh yes, I have a whole list. We can go down it. I could spend all day talking about it. So yeah, I think so we talked about guidelines. I mean, one issue I'll get a lot is screening. So we talked a little bit about Pap Smear screening for cervical cancer. Mammograms, that's another one. So at 40 is typically when we recommend getting an annual mammogram. So that's really important. So it's like the statistics wise, about 40,000 women will die of breast cancer every year. And it's like 4,000 women will die of cervical cancer. So you can really see the difference between screening for breast cancer versus cervical cancer. And whereas cervical cancer, first you'll have to get the HPV virus. Then if it doesn't go away, it takes many years for it to develop. That is very different from like breast cancer, where, if you're a 40-year-old woman, you could have a negative mammogram and then next year, boom, get breast cancer, and it can spread relatively quickly. So the word cancer is in both of them, but they're two different beasts, and really need to be viewed differently. So, a huge risk factor for breast cancer is age. So as you get older, the risk for breast cancer goes up. So that's really important to make sure that, you're getting the mammograms every year, and more so as you get older. So that's really important. One thing, you guys are into wellness and health and promoting health. And so we talk about that in annual exams. And so, one of the things we talk about is, I always recommend, hey, exercise is always a good thing. You should do that. And then I'll say, you should eat a great diet. What does that mean? Nobody really knows. I mean, there's a lot of controversy about that. And I certainly don't proclaim to be an expert on, I'm not a dietitian or about diet. It's really difficult to do studies with that. And to be honest, in medical school, they don't really go into depth about nutrition. I mean, we talk about, medical school, they like to talk about things that we really have a good grasp on, how the body works, pathology and pharmacology. But nutrition is really tricky. It's tough to make, like double blind randomized control trials, and there's so much involved. And it's like, do you look at it for a year or 2 years? And then how do you know they're really eating or doing what they need to be doing? And so what I typically tell people is I say, look, can't drink enough water, you can't eat enough vegetables, lean proteins. If you do that, you're probably going to be fine. I never have to tell people, hey, you need to eat more salt, sugar, fat, candy, donuts. That will find its way in there. And so it's tough, but I think moderation. It's like, look, I think we all, it seems kind of like common sense. You eat plenty of vegetables, whole foods. I mean, it's lean proteins. I don't think you can go wrong with that. What else
We
can
have
we talk about?
a friend that's a
Talk about,
trainer out here, and he gets people to actually get their blood drawn before he works with them, just to see if there's anything strange
Sure.
going on. Yeah.
Yeah, I mean, we know about cholesterol and heart disease and different things like that. So, as far as diet, it's limited. I mean, if you're eating, fatty foods all the time, obviously there are studies about that as well. So another thing we talk about is birth control, contraception. So that's a common conversation to have all the time. I mean, when I have my birth control spiel, so it's kind of like, okay, it's like, well, what are my options? It's like, well, you have a pill that you take every day. There's a patch once a week. There's a NuvaRing that goes in the vagina once a month. There's a shot every 3 months. There's an implant in your arm called Nexplanon every 3 years. There's an IUD or intrauterine device. There's several on the market, 3 years, 5 years, 6 years, and 10 years. The 10-year one has no hormone. They work very well. You have condoms, and then you have other things like the withdrawal method, rhythm method, diaphragm, spermicides. Some of those, I don't really recommend those because they have high failure rates. A lot of the, people say, well, what's the difference between them? A lot of it's preference, but they're the implants are really nice because they've come on the market and are very popular. And so if you're a younger woman and you're like, look, I want to go through my studies, I don't want to get pregnant anytime soon, I don't want to get pregnant, the insurance companies certainly don't want you to get pregnant because they got to pay for it. So they're like, well, what can we do? The implants are great because it's kind of a set it and forget it. So like the IUD, the Nexplanon, they're good. Some of them are good for 10 years where they have very low failure rates. You put it in and you set it and you don't have to think about it. So in regards to contraception, so you're not likely to get pregnant, especially if you don't want to be pregnant. And you can take those implants anytime you want out. So if you put an IUD, it causes some pain or causes some problems, you can just take it out, the next month if you really wanted to. Same with the implant. So those are great options for people who want to hold off on family planning for a while.
Are those relatively safe, the implants?
Yeah, they're very safe. It's kind of like anything. People will go, well, I read this online, and it's kind of like, I give the analogy like, look, if someone said, hey, look, I'm not going to drive a car because I know somebody who got in a car accident. Heck, no, they died. What's that all about? And it's like, yeah, no, it's true. People die in car accidents, but I generally like cars. I use a car. I recommend other people use cars if they want to. So with anything that you do, there'll always be some side effects. So like what I usually tell them is I say, look, if any of my family members ask, hey, is this a good thing? If, an implant, Nexplanon, IUDs, I say, absolutely. I would recommend it to any family members who wanted it. There are some very low risk for like IUDs specifically. It would be like uterine perforation or bleeding or infection, but those are extremely low. And then as far as the Nexplanon in the arm, they said, well, will it migrate? Knock on wood. It's never migrated with me. It will move a little bit. Maybe an inch, but it's not going to be like in your shoulder or in your neck or something like that. So I'm sure there are documented cases where it like was in the blood vessel or something horrible happened, but that's extremely rare. But they're great products and I would recommend it to really anybody. And really it's more kind of preference. So, another issue would be, so like the pill, the patch, and the ring, those have two hormones, estrogen and progestin. And so those are contraception where you'll have a cycle like once a month. And so, whereas the shot, the Nexplanon or the IUDs with medications, that one of the downside with those is you'll have kind of irregular bleeding. So you'll have kind of like light, unpredictable spotting every now and then, but usually the cramping and bleeding is a lot less. So if somebody is like, well, I want to have a period every month and I don't want to have irregular bleeding, then they kind of want to stay away from those and really either be on the pill, the patch, and the ring. And of those three, I would recommend the ring, because if you're doing it once a month, the way the ring works is they're all hormones that get into your body. They're just different ways they get into your body. So the pill you ingest, the patch, it goes through your skin, and the ring, it gets the medication's in the ring and it gets absorbed through the vagina, the medication. And so the ring, the pill, you'll take a pill every day. The patch, you'll put a patch on for a week. You'll leave it on for a week, take it off. The next week you'll put it on. So for 3 weeks in a row, you'll use the patch, three patches. The last patch, or the last week, you won't put a patch on. You'll have your period, and then you'll start that every month. So the pill is every day, the patch is once a week, and the ring you put in the vagina, you leave it in there for 3 weeks, and then the fourth week you take it out, you throw it away, you have your period that week, and then you start again the next month. So the ring is kind of preferable in the sense that it's just one thing that you do once a month, whereas the patch is once a week, whereas the pill is daily. And so if you're doing something daily, you're more likely to forget, you go on a road trip, and that's where people can get into trouble. And another thing, when it comes to birth control, so this is kind of important, is what you're doing with birth control, the pill, the patch, and the ring, is you're basically trying to prevent the woman from ovulating, releasing an egg. So every month, a woman's body is saying, make a baby, make a baby, make a baby. So every month, she's ovulating and releasing an egg. And so these medications prevent that ovulation from happening. It kind of suppresses it, kind of makes your body think that you're pregnant, and suppresses the from ovulating. So if someone's taking a pill every day, what you're doing is you're suppressing this level so that there's this hormonal rise. And when you get to a certain point in the month, you'll have this hormonal spike, and then you'll release the egg. So if you're taking a pill every day, it suppresses that. So if you miss one day, you can double up the next day, and you have enough hormone where it kind of prevents that hormonal spike in the release of the egg. But if you miss 2 days in a row, that might be enough gap where you could have this spike and release the egg. And once the egg is released, then you can get pregnant. So it's important to know that, because if someone's taking a pill every day, and let's say they're in the beginning, their cycle is in the middle of the month, and the first week they're taking their pill every day, then they miss it on the weekend. They go on a trip and they forget to take their pill. And then so they miss it Friday, Saturday, Sunday, and Monday. And then Tuesday comes on and they go, oh, well, I wasn't sexually active then, but now I'm going to be sexually active on Tuesday or Wednesday. I'll just take my pill and I'm safe. It's like, no, that's not how it works. So if you have that gap, you can release that egg and you can get pregnant. So if you understand what's happening, that's important, because if you don't know that and you think, oh, it's like a seatbelt, like, if I'm not driving, then I'm fine. But if I'm driving, I'll wear my seatbelt. It's not like a daily thing. So that's really important. And the other thing, lastly, is it's really important. It's like, look, when you're on birth control pills, it can help you not get pregnant, but it doesn't stop sexual transmitted diseases. So, condoms, are really important in that respect. So, I say, look, if you're driving a car and you're wearing a seatbelt, it doesn't guarantee you're not going to die in an accident, but it's way better to have a seatbelt, if you get in an accident, than not. So I always tell them, when you drive, always wear your seatbelt, if you know what I mean. So, there you go.
So as far as some of the patients that we see, so CrossFit, believe it or not, is probably half women, in some gyms, maybe even more so. Like they'll have some classes you'll go into and it'll be mainly girls working out. So, and obviously a lot of them get pregnant at one point in their life or another.
Right.
What's your view on exercise during different trimesters, or how should that be approached?
Yeah, that's a good question. Well, so Acog recommends exercising in pregnancy. It's a good thing. I mean, really one of the biggest things with exercise in pregnancy is just, and this kind of falls into your realm, is you just don't want to hurt yourself, especially in the third trimester where you're carrying all that extra weight, and you don't want to strain muscles, because you're gaining a lot of weight in a relatively quick time. And if you're, doing 400-pound deadlifts or something, and you're pregnant and you're carrying that extra weight, that's a lot of pressure in your lower back. So, that's one of the biggest things about exercise. So there's been some studies about trying to keep your heart rate down, below 140 and different things like that. But generally speaking, I don't think the evidence on that is very solid. So generally I say, look, if you're exercising and you're pregnant, that's a good thing. You should exercise. It helps with blood glucose levels. And so I usually say, look, it's kind of a common sense stuff. So, in the first trimester, you're pregnant, the baby's small, floating in a little jacuzzi inside the uterus. There's not much that's going to be hurting that baby. It's like just floating around, and you're fine. When you get in the third trimester, obviously, you can fall and hit your belly. You can trip. You can drop a weight or something, if you're doing kettlebells or something like that. That's going to be a, concern, obviously, if you have trauma to the abdomen. So that would probably be one of the biggest things. And then your weight distribution is off. So you're more likely to trip or something. I think I've seen stories where women are running, marathons in the third trimester. I generally probably wouldn't advise that, just because you could, you're walking, you're tired, your need for water increases, you can trip. And if you trip and hit your belly, that's a big deal. So stuff like that. So usually I say, common sense, third trimester, probably shouldn't be ice skating, probably shouldn't be riding a bike, anything where you can trip and fall, especially like with CrossFit or something, kettlebells, a lot of women, this was brought up to my attention that, I'd have these women where we do a hysterectomy or tie their tubes, we do surgery, and they were like, when can I get back to start working out? Like they were like ready to go on day one. And I was like, whoa, like, give your body a little chance to heal up. I mean, you still have Dermavon on these incisions that I made. And after talking to a lot of my patients, I realized that, a lot of them, they're like, look, working out is a huge stress reliever for me. And so it's, a lot of it is more just for like mental clarity, just kind of clear out my mind and deal with stress. And it's a big part of my day-to-day routine. And the sooner I can get back to that, the better, I'll feel about just life in general and getting back to that, that day-to-day routine that, they don't want to be held up for, a month. And I didn't realize that aspect of it. And so again, it's kind of like, so when it comes to pregnancy specifically, I generally will say, hey, keep the weight a little bit light. Walking is always a good exercise, and then just kind of avoid anything that you can have some abdominal trauma. So, but we generally advise to exercise in pregnancy.
I think it kind of goes through a logical cycle as we've talked through the early stages of like womanhood, I guess, and then now pregnancy. Would you touch a little bit on like postpartum and then eventually like menopause, and then we can kind of go through that cycle.
Wrap it up, make it full circle, right? Yeah. So, do you want to talk about the postpartum state, like just the few weeks afterwards and what they can expect, or just like further on years after delivering babies?
Maybe a little bit of both.
Sure.
Yeah.
Okay. Well, postpartum, it's pretty straightforward in the sense of wanting to rest your body and take it easy. I mean, if you think about it, you were pregnant and and then immediately you deliver the baby, and now the baby's gone, your uterus shrinks down, the placenta's gone, the fluid balances in your body change dramatically. You're probably anemic from bleeding from the delivery. Your hormones are now crashing. You're probably not getting any sleep. You're stressed out because you have a new baby. You probably don't know what to do. And, you're sore and achy, and, God forbid the coronavirus, you deliver on the year that you have the coronavirus. I mean, it's stressful. And so all that can just overwhelm women after they deliver. And if you don't have family, if you don't have a good, supportive network, and that's all on top of life's regular stresses, that can be very demanding and overwhelming. So depression obviously is a huge issue, and we screen for, we ask, how are you feeling? How are you doing? Are you getting sleep? Because I mean, as an OBGYN, I know what it's like to not have sleep. And when you don't have sleep, you're miserable, you're delirious, you don't think well, and life is just like really crappy. You're just like, nothing is good right now. And so that is, and for those women who've had babies, they know what it's like to have a baby who's crying all the time, who really up until that point was in this nice, warm jacuzzi with no light, with no cycle. And all of a sudden, boom, they're breathing air, you know, they have temperature changes that are fluctuating. They now have to use this gut that they've never used before because all the nutrients was coming through the umbilical cord, and they're gassy. I mean, they're crying all the time. It's like eating, I don't know, going to India, eating a bunch of food and being exposed to all this bacteria. You can imagine what it's doing to this poor baby's digestive system. And the baby's crying all the time. So the mom's tired, the hormones are crashing, they're stressed out about the baby. That can be overwhelming. Now, the good thing about that is as time goes on, everything gets better. The hormones start to settle down. You start to heal up and you're not as sore. The baby starts to get a little bit more of a routine. They're not as gassy as they start, drinking breast milk or formula, whatever you're using. And you go, okay, this baby is doing well. I'm not as stressed out. I think I kind of got the hang of it. And so everything starts to get better with time. And so if they can get through that really difficult time, a lot of encouragement's important. And so that's important. And if obviously there's some cases where people are having a very difficult time, and then you can talk about other options, like therapy is always a good idea. Everyone can talk to somebody. We all have problems. And so, if it's a really stressful situation, you have a new baby and you're stressed out with your partner, and sometimes it's difficult to talk to people that you're close to because, I'm a husband, and, sometimes my wife wants to just talk to me, and I'll be like, hey, well, what do you mean by that? We get defensive, and then it's like, no, I just want to talk about things. And so therapy is a great, non-invasive way to kind of help with a lot of these stressors. But there are some medications that can help. And there's an appropriate time to do that. So that's, the gist of postpartum in a nutshell. Now, as far as menopause, let's talk about menopause. So some people are like, well, what is menopause? And menopause is basically when you start to have a decrease in your estrogen levels, and your body is basically saying, okay, we're closing shop, no more babies, let's just stop. And when you go through this transition period, you can have symptoms. So the technical definition of menopause is someone who's gone a year without any menstrual bleeding for a year due to lack of estrogen. So obviously if someone's pregnant, they're not going to bleed. That's not menopause. So menopause usually starts mid to late 40s, but it can start in the 40s. And the average age where women stop bleeding altogether is 51. So if you start to go through menopause before 40, we call that premature ovarian failure. So women will can start feeling symptoms or having symptoms earlier on, and then it peaks, and then it will kind of dwindle down during that period. And that's kind of what we call this perimenopausal stage. And that stage can last roughly about 5 or 6 years. I mean, it varies from woman to woman, and the severity will vary from woman to woman. So the symptoms can include hot flushes, night sweats, mood changes, decreased energy, vaginal dryness, decreased libido, hair, skin changes, usually for the worst. Unfortunately, some of those symptoms are also symptoms as we get older. We can tend to have less energy. It's harder to lose weight. And, if you're going through all those or you're feeling those symptoms, those are not fun symptoms, I can imagine. And so women are like, what is going on? What can I do about it? What's the deal here? So again, when you're 20 years old and your body's like, make a baby, make a baby, make a baby every month, you have high estrogen levels. Your ovaries have, and the estrogen levels are primarily coming from your ovaries, and you're ovulating every month, and so the estrogen levels are high. Well, as you get older, the estrogen levels start to drop down, start to drop off. And when it passes a certain threshold, you'll start to have symptoms. And it varies from woman to woman. So some women, I think it's like 90% of women will have hot flashes. So you can start to have hot flashes every now and then they pick up and they get worse. But it could be mood changes. It could be problems sleeping at night, like I'd mentioned before, all these other symptoms. So it could be some women can have some of them. Some women can have all the symptoms. Some women can have hardly any symptoms. And so you'll start to have the symptoms. Like I said, it'll get worse and then it'll tend to taper down. Now, when you're at the end of it and the symptoms have stopped and you've stopped bleeding, one thing that will happen and will kind of persist ongoing is you won't bleed anymore. So you won't have like the bleeding and cramping. Eventually that'll stop. And then, like the vaginal dryness, the decreased energy, that tends to be there, indefinitely as you get older. What the fluctuation symptoms that tend to stop are typically like the hot flushes, the night sweats, and the problem sleeping due to the hot flushes and the mood changes. So that typically during that transition, those symptoms will kind of go away, and then you're kind of left in a postmenopausal state. So, a lot of times, the analogy I use when someone's going through menopause is like, if you're driving a car and you're running out of gas and you sit there and all of a sudden you start going, put, and it starts jerking the car because you're running out of gas. You're like, hey, how long is this going to last? This is horrible. That's kind of like menopause. You're running out of gas. How long is it going to last? It varies. It depends on each woman and how severe it is. So one question is, do I need to do anything about menopause? And the answer is no, you don't need to do anything. You can just, if you don't have bad symptoms, you're like, okay, I don't necessarily need to do anything. I don't like the symptoms, but if you want to go get, just kind of go through it, that's fine. It's not going to hurt you to not do anything. You don't need to be on any kind of hormone replacement therapy. But hormone replacement therapy is an option for those who are like, I can't sleep at night. I'm going crazy. Like my mood's all over the place and it's just horrible. I hate this. What can I do about it? Hormone replacement therapy is an option. Now, what are the risks with hormone therapy? Replacement therapy. Well, there's a big study called the Women's Health Initiative studies where they looked at hormone replacement therapy and what kind of effects and risks that they have. So typically the big risks would be a risk of breast cancer and a risk of stroke. So that's serious, dangerous things that nobody wants, obviously, but the risks are relatively low. I mean, it's typically about 1 in 1,000, the risk of getting it, where you would getting breast cancer or a stroke is about 1 in 1,000 for every year that you're on it. So 1 in 1,000, it really depends on your symptoms. So if you're having severe symptoms and it's affecting your daily life, and you are like, well, give me the medication, I'll take the 1 in 1,000 chance, especially if they don't, I mean, I would only give hormone replacement therapy for someone who doesn't have like a contraindication, like a history of breast cancer, or they've had stroke before. And those are typically, those are contraindications where you wouldn't want to put anybody on hormone replacement therapy. But assuming they're relatively healthy, you can try them on that. And then you treat them really for symptomatic relief. So you go up on the dose until the symptoms pretty much go away. So you can try it for a year and they can go, oh my gosh, my symptoms are so much better. I'm sleeping better. I feel better. Try it for a year. You want to try the lowest dose instead of going up for the symptoms to go away. And then after a year, they can stop. You can say, hey, stop for a couple of weeks, see how it goes. And if they go, yeah, the symptoms aren't that bad, I don't need it anymore, then don't take it. If they're like, my symptoms are horrible, give me the drugs, they can start it up again. So, it's kind of like Tylenol. If you don't have a headache, don't take Tylenol. There's no point in it. But if you do have a headache, and depending on how bad the headache is, Tylenol might be an option that you might want to take, similar to that.
And they would go to your office to do that type of consult for
Yeah. Yep. I have this conversation every day. So yeah. And, nobody wants to go through these menopausal symptoms. There's also a question about, hey, can I take some natural supplements, or is there something I can take other than hormone replacement therapy, like black cohosh or, soy products? And they've actually done a lot of studies on that. And at the end of the day, they don't really work. there are some patients that go, hey, I take this supplement or this tea and it works great, or I have some soy. If it works for you, great. Do that all day long. I would much rather you drink a tea or take a vitamin supplement than hormone replacement therapy. But when you look at like a double-blind randomized controlled trial and you're looking at it, a lot of the supplements, certainly the studies I've read, haven't done better than placebo. Whereas the hormone replacement therapy, because someone didn't know what pill they were taking, the hormone replacement therapy alleviated the symptoms dramatically. I mean, it was pretty obvious. So it's kind of the gold standard until we get some other better product that's safer. That's ideal. I mean, there's researchers always looking for it.
Have you noticed any difference in someone that's more active as opposed to someone who's not? Like if someone is like a CrossFitter or they do go work out a lot, have you noticed that their symptoms seem to be different than somebody that self-admittedly sits around or that they are not as active?
That's a good question. I would say that one thing it really helps people being active is energy levels. So that seems to be kind of a universal thing, that if you exercise, you're going to feel better. You're going to have more energy, believe it or not. So, and I find that actually true in my own life. So, I mean, anecdotal evidence is like, look, if you work out and you exercise, you'll have actually more energy and you'll be able to deal, just mentally, it seems like it clears out people's minds, and there's huge benefits for exercising. So I find that to be the biggest issue. But as far as hot flushes and night sweats, I don't know if it makes any difference working out or exercising that. But it's kind of like if you're exercising, that's always a good thing. You should always do that, period. Hormone replacement therapy or menopause symptoms or not, right?
Yeah. I've had someone before, people will tell you, well, I don't have the energy to exercise. And you're like, exactly.
Right. Yeah. No, it's kind of strange. You wouldn't think that'd be the case, but actually it is. And yeah. So, but to answer your question, as far as hot flushes, night sweats, like vaginal irritation or dryness, no, I don't see that. And I haven't read any studies that show that.
Gotcha.
I know. So you just had your practice open last year and you're getting into jiu-jitsu in general, but is there anything, physically, mentally, just something that you're excited about that you're working on?
Oh, that's not enough. I need more. It's keeping me busy. The practice, my kids, my wife and kids, trying to eke out some fun stuff in between that, and jiu-jitsu. Oh man, that's it. I'm done. No more projects.
All right. I love it.
Yeah, jiu-jitsu is a good one too. I have some friends that have been pretty into it, and that can keep you busy for a while.
Oh my gosh, I've never had so much fun getting my face smashed in and paying them to do it. It's pretty amazing. Yeah. Well, I'm doing these podcasts nowadays, right? There's this famous couple that's doing podcasts. They're awesome. They're taking Joe Rogan on.
Someday.
Yeah.
You did mention diet earlier. What's your favorite cheat meal?
Oh, I have so many. I don't know. That's not a problem. What's my favorite cheat meal? You didn't prep me with this. You didn't prep me for this. I have so many. My gosh. My favorite cheat meal. Oh my gosh. I hate to say it. I probably shouldn't say it. I love McDonald's. I love me some McDonald's. Yeah. Yeah.
What's the order?
And there are millions of other people that's their favorite cheat meal.
Yeah.
Too. Yeah.
What do you get there?
Oh, I'm late. Oh, I just order like a Big Mac. Sweet tea. I like sweet tea. That's horrible. I got to get away from that. I'm drinking a lot of water. You'd be very proud of me. I'm drinking a lot more water now.
That's really good. What's something that you wish, or that that you wish people knew sooner?
Something.
That you learned. I'm sorry. Something that you learned that you wish other people knew sooner. It could be anything, job related or just in life in general.
Something that I learned that I wish I would learn sooner. You can live off of 80% of what you make and be fine. And if you take that extra money and invest it and save it, you'll be fine the rest of your life. I wish I would have learned that a little bit sooner. I'm teaching my kids that, by the way. They hate it. Come on, give me all my money. Like,
right?
No. Yeah.
And then what's something that you want to leave the listeners with?
Something I want to leave the listeners with. Well, I think, I guess there's, I would say since we're talking about women's health and everything, I would say that, well, I guess if I should do a little more broad range, um, I'll throw it out to the guys too. I won't just do a female thing. I would say, well, let's just talk about jujitsu. So I was really excited about jujitsu. I wanted to do it for a while. It's hard when you've had a long day and it's difficult to get out there and do exercise, especially intense exercise. It's pretty difficult to do, but it's been, it's something I'm motivating myself, pushing myself to do. And I'm doing it with my son, which is really cool. So we're having that bonding time. I would really want to encourage everybody to, especially in these turbulent times, pretty chaotic times, COVID and everything happening, get out there and do some physical exercise, push yourself, it'll pay dividends. And if you can do it with somebody that you have a great relationship with, it's a bonding experience. My wife walks with a group of women. They have a blast. I'm doing this with my son. It's really awesome. I love doing it. So I do. So I go to Carlson Jiu-Jitsu in Henderson off of Eastern. That's a little plug. Maybe I'll get a month free from that.
Okay. Very good.
And how can people find you?
Oh, they can Google me. They can Google Dr. Tanita. It rhymes with fajita, but there you go. Tanita's Tanita. My practice name is Henderson Women's Care. So they can go to hendersonwomenscare.com. Or they can Google my name. I'm all over, Yelp. They can do Yelp.
And do you have any kind of a Facebook or Instagram that you use?
I most definitely do.
Okay.
My wife does the marketing, so I'd have to talk to her exactly where it is. I mean, I guess if you just do a search for Tanita or Henderson Women's Care on Facebook, and I think Instagram isn't owned by the same company. It's kind of linked together or something.
Pretty much.
Yeah, and we'll provide it in the show notes as well.
Mm-hmm.
I'll talk to my marketing person.
Okay.
Very good.
Yeah.
All right. Well, we really appreciate your time. Thanks for being on the show. I'm sure our listeners learned a lot.
Oh, I learned a ton too. So thank you so much.
Great.
For that.
Awesome. Yeah. Thanks for having me.
Really enjoyed it. We'd like to thank you for listening to La Vida Las Vegas podcast. We hope you enjoyed the time with our guests as much as we did. It would help us out so much if you could share, subscribe, or review our podcast or any combination of the three. Thanks again, and remember to take care of yourself.